In this section, we're going to talk about the psychosocial assessment of the older adult. When you look at some startling statistics, more than 50% of older adults have 3 or more chronic diseases. And I had been saying patients with multiple comorbidities, but I used that term incorrectly, as I pointed out in class. The term should be multimorbidities. And multimorbidities, you're seeing higher rates of death and disability, longer-term care usage, and a greater expense of healthcare dollars, and really out of all of it, not achieving the kind of quality of life that the older person expects upon retirement. So what we're finding is that early identification and intervention actually serves as an excellent and critical prevention strategy for the older person. Now, geriatric syndromes is the name of the term that we're talking about here, a number of conditions typical of, if not specific to aging, and very much the ones we've been talking about, like dementia, depression, delirium, as well as future topics we'll be covering, like incontinence, vertigo, falls, spontaneous bone fractures, failure to thrive, and even neglect and abuse. And geriatric syndromes are what are associated with a reduced life expectancy of the older adult. When we look at psychosocial assessments, the assessment of psychosocial function really is essential to providing holistic care of the adult, but it's a complicated and complex process. And I showed Maslow's hierarchy of needs here as a graphic there, because it does emphasize the physiological things that are necessary and all the way through what a person needs, let alone an older adult needs. And a good psychosocial assessment can help identify multiple changes, from cognitive and medication-related changes, and looking at mind, body, spirit needs that the nurse needs to be looking at, as well as developing good therapeutic communication skills and asking the questions appropriately to gather the data that they need to provide that optimal level of care. But also knowing when someone like social services needs to intervene and use their skills and scope of practice. But all those are relevant assessment tools that are key for the practicing nurse to understand. Know when your scope of practice is appropriate, provide holistic care using therapeutic communication, and know when to seek out additional help if it's beyond your scope of practice. So I posed the question in class, are you providing true holistic care of your patients? And the American Holistic Nurses Association came up with the definition as all nursing practice that has healing the whole person as its goal. And that should really be tantamount to the type of care that all nurses provide. I pointed out that learning the skills is important, all those things that you've been learning in skills lab there, but these are the ones that can actually be taught to the patients to do themselves. Certainly overseen by a nurse and with a registered nurse doing the teaching, but all these things are taking place in the home, and many times overseen by the nurse, of course, I should say, but done by the patient themselves. So psychosocial care, studies have shown that providing it can enhance patient outcomes, it can reduce anxiety, stress, it can even decrease the time of hospitalization and enhances coping, reduces levels of pain. Overall, it increases the quality of life. So the purpose of the psychosocial assessment is to do all of these things, because common adjustments that occur with aging include family changes. The children grow up. The role within the family of the patient might have changed multiple times in their lifetime, and sometimes the role completely reverses. They've gone from being caregiver of their children to children being their caregiver. Retirement can be a difficult time because we look forward to that time when we're going to have free ability to do things. But a lot of times work is a person's social outlet, a source of social contacts, and they get a feeling of satisfaction from the productivity that now is gone. They also, as they get older, develop an awareness of their own mortality, because not only are spouses possibly dying, but their friends are, and they may be seeing a health decline that's got them thinking, am I next? So often older adults review the significance of their life through reminiscences, telling stories of their life events, and they really should be encouraged to tell stories because they a lot of times face multiple losses at one time, but also keep the present in mind as you're working with that patient as well. Now, in doing a true psychosocial assessment, you need to identify the unique meaning of life events to that person and let them talk about their life. Make sure you include important things to them in their life, like their pets. How do they view their medical conditions and their limitations that they might be having in terms of their well-being? Are they working above it to get better and get back moving again, or are they seemingly giving in to the condition and saying my life is pretty much over? Because that will affect the type of care that they have. And most importantly, you have to stay non-judgmental during the whole process, both verbally and visually with nonverbal communication. So as a psychosocial assessment is taking place, you're talking with the older adult and probably their family member or caregiver, but you're also observing them, looking for their nonverbal reactions and developing a caring line of questioning based upon that. And it's usually done at admission time so that you have a baseline of where they're at and where you're working toward. But developing that trusting relationship through therapeutic communication, simply providing a listening ear and a sensitive heart, really will make the differences. You also have to recognize that there may be cultural differences which may require a need for clarification of messages because different people do things different ways. Then when you're assessing the person, you want to assess their cognitive level. Now, the MMSE, the Mini Mental State Examination, is one of the oldest and most widely used brief screening instruments for cognitive impairment. Due to copyright restrictions, I can't show that to you on the screen here, but you certainly can go online and see pictures of it in many different places there. And it's been used in a variety of settings, including screening patients initially on assessments, seeing how they're doing over time, and also in population settings with larger populations and during clinical trials. So it certainly has its benefit, but there's a cost to it now, as we talked about in class. So as a result, other types of assessment tools have come into place as well. One of them being the brief interview for mental status, BIMS, which is still available for people to use freely with attribution, of course. And the BIMS does very similar job in terms of identifying cognitive status, which ultimately gives a score that falls into one of three categories: cognitively intact, moderately impaired, or having somebody with severe impairment. And this is what affects decision-making and executive function. Now, executive dysfunction is a term used to describe the range of cognitive, behavioral, and emotional difficulties which can occur, I should say, as a result of some type of disorder, possibly dementia or such, or a traumatic brain injury. And when they have executive dysfunction, they end up struggling with planning, with problem solving, with organization, and with time management. The things that they used to do to make their own decisions become more difficulty. And you might hear this in a competency hearing for an older adult at some point, stating the person is no longer decisional. And by being decisional, they're no longer decisional. They can't make safe and correct decisions for themselves regarding their own care or well-being. And as a result, somebody may be appointed, or a family member may be placed as a durable power of attorney for healthcare or as a legal guardian to make healthcare decisions for that person. Then there's affective function. Keep in mind that affect includes the facial affect of neutrality and the 8 primary affects of interest, enjoyment, surprise, distress, fear, shame, contempt, and anger. We normally show emotions. But when somebody has a flat affect, they might not be showing any emotion there. And that's something to be watching for as you're interviewing that person. There are tools to help available to help assess, I should say, the affective function. One of the biggies is the Geriatric Anxiety Inventory, or GAI, for assessing the level of anxiety. And those are available online, and actually electronic ones are freely available now too. And the idea is to identify different common anxiety symptoms there, and the measurements of somatic symptoms that are symptoms that are overly focused on by an older adult are limited, so that there's not really confusion between symptoms that are common to anxiety and those of general medical conditions that can occur as the older adult is aging. But it does help provide some kind of a understanding of where the person is at in terms of self-esteem, depression, or happiness and well-being. Kind of a different from a loss of contact with reality, which can occur sometimes with cases of dementia, delirium, psychotic disorders, where they have delusions, hallucinations, and illusions that can affect what's really going on in life. Notice the parallels that are drawn with delusions and hallucinations in terms of different common medical conditions that can be occurring: dementia, depression, and paranoia. Now, when you're dealing with older adults, they may try to conceal these delusions and hallucinations to not look like they're having problems, and out of fear of being tossed into the brink, the nursing home there or something. And it actually can be a result of something like social isolation, and many times getting them back into a societal type setting actually will provide some improvement in those areas. But you have to look at what the underlying conditions are, the potential effects of the environment and interpersonal factors, and also cultural factors that could be explaining some of what appears to be a loss of contact with reality. For this, you may need to have somebody beyond the nursing scope of practice, such as a psychiatrist or a psychologist. And remember that delusions are associated with different pathophysiological conditions, as well as the other ones we've mentioned. But it really becomes sort of a psychiatric imbalance, again, that may need, again, a different scope of practice to be supportive. So don't be afraid to refer to the appropriate people as needed. Social supports are so important. Informal support might be family members and friends, while formal social support can actually include the doctor and visiting nurses in a home health care situation. And they affect the ability to cope with stressful life experiences, and nurses need to assess what those social supports are. Are they good ones? Are they strong ones? Are they dependable ones? Or are they ones that may be on the surface looking good, but not providing what that person needs? So what you can consider is referral to a qualified social worker to work on these things, because it becomes the nursing responsibility if no social services are available. But home care agencies, for example, will usually have the services of a social worker available. Lastly, remember the importance of religion and spirituality. Not everybody is deeply religious as they get older. It might be contrary to some popular belief. But spirituality oftentimes exists even in a person who claims no specific religious affiliation. So it should be assessed as a separate component. Sometimes religions somehow can actually make an older adult feel guilty for having anxiety or depression, and yet it's those same religions, if they know what's going on, want to help. But it needs to be looked at, the difference between spirituality versus being part of an organized religion and what the patient needs. So make that an area that also has importance in assessing the needs, because they may need to talk more about how they're feeling about what's happening and what God might or might not be doing for or to them. Thanks for listening.